Hi, welcome. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center, and I'm the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. This series is funded in part with a grant from the Rosalie and Sherry Exline Ziegler Fund. And I have a friend and colleague as my conversation partner tonight, Dr. Valerie Stratton. Welcome, Val.
Hello, everyone. Thank you.
So Valerie is an amazing person. So Valerie is grew up in Des Moines, Clear Lake area, not Des Moines, Iowa, Clear Lake. And she was a nurse as the first part of her profession, and realized that she had more that she wanted to learn and more she wanted to give. So I went back to medical school at Des Moines University and did an internal medicine residency. And she's got some specialty training in menopause issues and women's health. And I invited her to be here because we want to have a conversation about women's health and the intersection of women's health with cancer. So welcome.
Thank you very much. Yes, so I'm part of the MercyOne Comfort Health Center for Women, and we do specialize in premenopausal, perimenopausal, menopausal women, and all issues that they have, and then you throw cancer on top of it and the treatments, and so we treat all those types of patients.
Yeah.
So there is a certification called North American Certified Menopause Practitioner. So we're the practitioners there are certified by them. And then we're also very active with, it's called ISWISH, which is the long name, International Society for the Study of Women's Sexual Health. And that's about, trying to help midlife women or whoever that are having any aspects of their intimacy relationships and sexual health because of medical conditions, improve that. So those are kind of our specialties within that.
So
clinic.
Valerie, with all of your training and credentials, do you fit on one business card?
Yes.
Like if you
Yeah.
put all of the
It's
initials behind your name?
It is a lot. That's right.
Yeah. So
Yeah.
BSRN, DO, and then all of the others.
Yeah.
So obviously you're a woman, so I would expect that you would have an interest in women's health by being a woman.
Yes.
But when would you say in your professional career in medicine, nurse, doctor, internal medicine, did you decide that you wanted to have an emphasis on women's health?
So naturally, being a female physician and doing general internal medicine, you attracted a larger crowd of females. And just throughout our training, you just look back, and even talking with OB-gynecologists, the amount of training we get on menopause and sexual health is very small. So you just felt this empty gap.
Mm-hmm.
And then you start learning about it, and it just gets you very excited that there are things to do.
Mm-hmm.
And that it's different for every person. I'll have people come in and say, well, I'm going to send my friend to you. And I say, it's just what I'll tell them may be different than you, because there's just so much individualization. And then, of course, getting more toward menopause, or initially toward menopause age, and now I'm past that, going through those things myself. But I just feel there's a gap there. That's not quite filled. Primary care doesn't have the education either. A lack of time. They got short appointments. OB-GYNs really kind of focused on babies and the surgical part. And so this gap of what do we do, perimenopause, menopause was just an unmet need.
Mm-hmm.
And so that's where my interest came from.
Yes. And as a cancer doctor, I see that gap. Certainly in medical school, I mean, you learn physiologically what menopause is, but really the issues and how to address them, and even I would say the conversations to have around menopause, but then the bigger issue, sexual health.
Right.
When do you have those conversations? How do you have those conversations? What's the proper way to have those conversations? And especially as a man with a woman, and getting into those topics, do I need to have a chaperone present as I'm opening these conversations? And then when you look at, and one of the reasons that I was really excited about having you as my guest is that many cancer treatments affect female sexual health. And sometimes you take a perfectly healthy premenopausal woman who just has a little bit of breast cancer that's highly curable, but in the act of going through curing a small, highly curable breast cancer in a premenopausal woman, you may wham, just
Absolutely.
throw them into menopause, and their breast cancer may have been not symptomatic at all, found as a little speck on a mammogram, and all of a sudden now their major health issue is not the breast cancer, but the premature menopause.
And I think it's the comfort level too, like you say, especially, I mean, they may be willing to talk to you about hot flashes and night sweats and sleep and mood, but talking about vaginal dryness and how this has affected the relationship with my husband, those are harder to bring up and harder for, like you say, providers to bring up, just because it's pretty personal and it does take a lot of time.
Mm-hmm. Well, go ahead.
But I was just going to say, when you look at the statistics for women, I know there's men in the audience, but for the women in some form of sexual dysfunction after cancer, I wrote them down. So if you have any form of gynecological cancer, so ovarian, endometrial, cervical cancer, it can be almost 100%, but 70 to 90% of women, if you outright ask them, have problems. Breast cancer, 40.
And you alluded to the men. Well, guess what?
They do too. Yeah.
But if a woman is having sexual health issues, her partner is having sexual health issues
absolutely.
as well. So
Absolutely.
so even if we were only talking about women patients, but I'm sorry, I interrupted.
No, yeah, but and the rectal cancers and the pelvic radiation, like 90%, and breast cancer 40 to 80%. And most of them wish that their doctor would ask them about that.
Yeah, or have let them know ahead of time that this is something.
Just a lot to cover ahead of time.
It
So they're not
is.
thinking at that time that will impact them. And so, with cancer patients, some of the ones that are at higher risk to have sexual dysfunction is the diagnosis at a younger age. If they've had a new partner recently and don't have that long-term relationship with that partner, if they have pelvic radiation, the abrupt menopause, like you say, that you put them into, all of those things increase the risk. So we see women every day that are suffering with menopause, but then you throw the cancer on top of it, and that's just a lot to deal with. Body imaging, scars, stomas, uncomfortableness. And a lot of women, the men are very supportive and don't want to hurt their wives. So all of that plays a role. It puts women at a lot of high risk for sex. So sexual dysfunction means several different things, which we can get into.
Yeah,
what that means.
Yeah. Let's maybe, for the purpose of framing our conversation, maybe talk a little bit just about menopause in general, not necessarily related to cancer, but let's explain a little bit about menopause and some of the common symptoms, and then also what you have to offer as a specialist who specializes in menopause, besides being a good listener and commiserating with them. When should someone going through menopause seek medical attention, as opposed to just, well, I guess this is what it is, and I'm just going to roll with the punches. So maybe talk a little bit about management of menopause.
So whenever they affect the quality of life, so whether that be hot flashes, night sweats, sleep issues, mood issues, vaginal dryness, decrease in libido, it doesn't matter if you're premenopausal, perimenopausal, or postmenopausal, because it varies with everyone. But that's
for those who don't know, perimenopausal.
Oh yeah, sorry. So premenopause is you're having regular periods. So those women don't have so much trouble with hot flashes and night sweats, but they can start to have a decline in libido because of birth control pills or other issues. But perimenopause is that time where your periods kind of start to change, can last 5-7 years till you get to menopause.
So it's kind of an irregular period.
So they're having periods, but yet I'm still having hot flashes. I have all the symptoms of menopause. They're just not menopausal yet. Okay. So menopause is once you haven't had your period for a full year.
Okay.
And then eventually you're postmenopausal. And so some of those hot flashes and night sweats can go away, but the other estrogen deficiencies, your bones, the vaginal dryness, libido, continue to haunt you all the way. So I've always said, I'm not sure you can tell me the exact percent. Like if you live to age 80, what percent of women get breast cancer?
You know,
Like 12% or something
yeah,
like that.
1 in 3 women in their lifetime.
Lifetime. So up to
And
90.
that's getting, yes.
Yep. So if you live to 90, 100% of women are affected by menopause.
Yes.
So,
Okay. Gotcha.
yeah. See,
Yes.
so I mean, so if
Yes,
you live long
right.
enough, you're really going to be
Yes, the
affected by it.
entire female population. Yes.
Yep. Some form. You may not have the active symptoms, but you definitely have the deficiencies. So the Women's Center, for those of you who don't know, it's kind of multidisciplinary, or it is all multidisciplinary like yours. So we have the catchment breast surgeons there. We have plastic surgeons that come and they can see them on the same day. We have lymphedema, pelvic floor physical therapist, a urogynecologist, full-time mental health specialist, a chiropractor, and then our menopause clinic.
Mhm.
So same type of thing. We try to address those different needs and coordinate appointments. So if you come to me, it might be like, oh boy, you really need pelvic floor. Right here in neighborhood
Mhm.
B is
And why would
Joanne.
someone need pelvic floor
Yep.
therapy? And why would someone need a urogynecologist?
Yep.
So how do those specialties play
Come
into
into that.
women's health?
So with the pelvic floor, people think about it as like doing Kegels, like, you know, I've had kids and now I cough and sneeze, but it's a lot more than that.
So leaking of urine.
Leaking of urine.
Yeah, so that's an issue that happens as women get older, especially if they've had vaginal deliveries.
Yep,
That can
yep.
affect it. And as we get older, our muscle tone everywhere
Yeah.
isn't as good. So women who are postmenopause have a higher risk of having leakage of urine.
Yep. Ideally, every woman who had a baby would have pelvic floor right away. So
Pelvic
then
floor
as they
exercises.
right away, so
Yeah.
then as they age,
Learn
it
how to
doesn't happen
strengthen
as
those
much.
muscles
Yep.
that help.
Because a lot
keep
of
the
women
urine
who
in.
really exercise and really strengthen their core, they could actually do the opposite to their pelvic floor because they're strengthening
Gotcha.
too much here.
So if you
and it
focus
puts the
just
wrong,
on your abs,
Right.
you
Yeah.
may not develop the muscles that help.
So these
Control.
two gals that are there, that's all they do every day, all day, as far as a physical therapist, is just pelvic floor.
Pelvic floor
They
physical
help
therapy.
men also, prostate cancer patients. But also, speaking of sexual dysfunction, with the vaginal dryness, it's not just dryness. The vagina loses its elasticity. The canal can shorten. You get that radiation. And so the painful intercourse, they can help them determine what's the best dilator to use. And I mean, you can go online and look at it, but they feel their musculature and say, here's your problem, which may be different than just the video you see on TV. So they can help them with the painful sex. Fecal leakage, who wants to talk about that, right?
Mhm.
So a lot of women will leak a little stool, and so they can help strengthen the rectal tone. So that's what I always use my hands. I'm like, it's everything right down there.
Yeah.
And I mean, I can tell you when something's wrong, but I can't exactly fix
Yeah.
that. So then we send them to pelvic floor physical therapists.
So we're going to get into the particular side effects and symptoms related to the cancer treatment, but let's, for the sake of conversation right now, talk about just a natural menopause and natural aging. So obviously, sexual dysfunction, loss of good control of urine, and loss of control, total control of feces can be issues that are related to normal aging and menopause, correct?
Right. We hate to say normal.
You're
it's
right.
not
Normal is
normal,
maybe-
but it's not unusual. Right.
Yeah, and I guess I meant
Right,
as
I know.
opposed to just a
Yeah.
side effect of cancer or cancer
Oh,
treatment.
absolutely.
Yeah.
Absolutely. I mean, this, like I say, this is what
Yeah.
we see every day. And then when you add the cancer on top of it, it just can make it happen
Mhm.
earlier or more significantly.
So let's talk a bit about the management of menopausal symptoms. And, I'm thinking of obviously hot flashes, but I'm also thinking of emotional lability and tearfulness and, sexual dysfunction that comes with the vaginal dryness. So let's say there's not radiation or chemo or hormone therapies related to cancer, but how would you approach evaluating a woman with those symptoms, and what are some of the remedies that you are able to provide to help women that are going through menopausal symptoms?
So healthy early in menopause women, hormone therapy can be very helpful. So that's where kind of the internal medicine comes into, because we can weigh their risk factors and see if they're a good candidate for hormone therapy. Otherwise, when we look at non-hormonal options, we try to look at which is going to cover the most, because I could give you this, and this, but maybe there's one of them that would cover 2 or 3 things. So if it's sleep and night sweats, it might be one treatment. If it's more mood and decreased libido, it might be a different treatment. So we use this menopause rating scale, and it goes all the way from hot flashes to how's your sleep, how's your irritability, how's depression, how's your sexual function, how's your bladder. Women with lack of estrogen start to get a lot more joint pains. How's your joint and muscle pain? They can get more palpitations. And so they rank all of these. So then we look at what is the worst for one person, and we can talk about hormone options and non-hormone options.
Mhm. And that's when we get just talking about cancer, that's really important, because
Right.
Someone who is at average risk for breast cancer going through menopause, taking estrogens for a while
Right.
is not a huge risk, but someone who has estrogen receptor positive breast cancer who's now going through menopause, giving that person estrogens can be very risky.
Right. So we have definitely some good options that are non-hormonal. And then of those, like different antidepressants, you got to be careful because some of them you can't mix with tamoxifen, but certain antidepressants. So if somebody's got hot flashes and night sweats and the mood, that would be a good choice for them to kill 2 birds with 1 stone. Somebody who's like, I'm not sleeping well and I'm irritable and it bothers me at night, there's like gabapentin. There's actually an overactive bladder medication called Oxybutynin, which is it's almost like a miracle drug for these women with hot flashes and night sweats. They come back and are very happy. And Oxybutynin has been shown that it helps, even though it's just fixing hot flashes and night sweats. When it's that bothersome and disrupts your sleep that much, it helps mood, helps overall life enjoyment, helps attending social events. There's clonidine, a blood pressure patch. So we can look at which of those non-hormonal options would best fit that person symptoms. And of course, there are other lists of medications and which one might be the best option to manage it. Now, there a lot of times by the time to get to us, some of the other things that they try just haven't helped enough. They're looking at acupuncture, the yoga, deep breathing, because our brain's very, very powerful. So even if it doesn't change like the number of hot flashes and night sweats, it can help you feel like you have some control, and it can give you a sense of a decreased impact on the quality of your life. So cognitive behavioral therapy, yoga, acupuncture. But a lot of times by the time they get here, they're kind of like, oh, beyond that, they're ready for a pill. Some of the over-the-counters aren't that great with helping, and just because they're over-the-counter doesn't necessarily mean they're safer. Like black cohosh can, after 6 months, can be associated with liver toxicity. Vitamin E is slightly better than placebo. Some of the others just aren't better than placebo. But our brains are very positive, so if we think it's going to help, it can help. But so we will go over some of those things with them also, but usually they're really at the point of wanting some sort of medication for a while to calm the symptoms down. Because even if we do have them do cognitive behavioral therapy, that's going to take a while. So what do I do in the meantime? Well, let's try this medicine in the meantime. Then we reevaluate.
And what's the process by which you meet with the patient, spend time with them, go over the symptoms, and then let's say you're going to intervene with a medication? How would you do the follow-up to ascertain whether that's been effective?
Yep. So usually we start with the lowest dose. So I kind of tell them, like Oxybutynin, they're going to know within the week. But if it's one of the other ones, it may take a few weeks. I say, I really want to see how you're doing in 2 months, but I have them contact us at 1 month. Do they want to stay at the same dose or go up? That can be by the follow my health message in the computer, a phone call, or if they're happy, they just refill it. But then I usually see them back at 2 months, and then depending on how they're doing from there, it could be 6 months. But yeah, our appointment times to begin with the consults are a little bit longer, which is the goal of the MercyOne Comfort Health Center for Women. So we actually have time to hear them and explain what we're doing. So that first appointment is a little bit longer, which is very nice.
And would you say that typically a woman would come in by herself?
They do, but I definitely like it when they bring their husbands or significant others, and some of them will do that because for them to hear the options of treatment, but most come by themselves. Yeah.
And then, so we talked just generally about menopausal issues, and some of that is sexual health, but just focus specifically on sexual health. And again, let's talk about patients who don't have a history of cancer, that haven't had cancer treatment. Do you find that they tend to go to their OBGYN first, or how do patients come to the Women's Center and find their way to see you?
Yep. It's both. Sometimes they've been to the gynecologist and then they come, their primary care, learn about us now. They're like, oh, I'm just not quite sure whether you should do hormone vaginal treatment or not. And then women are becoming more aware of Menopause Practitioner and will Google and find menopause clinics. So they get there all three of those ways. But I'm really surprised how many just type in menopause and that they know there are people certified in it. So that's how they come. Yeah. With the sexual health part, I mean, it really has to break down. Sometimes they'll say, I have a low libido, which can start happening, at age 30. But you kind of break that down. Is it really libido? Is it, because they're having the dryness and lubrication? Is it the painful intercourse? Because once you have painful intercourse, those pelvic muscles that we were talking about, they have memory. And even though you don't tighten, they do. So it's that's why the pelvic floor comes in handy with that. But other women, because when you don't have estrogen down there, the skin gets thin. There's adhesions that make sex more painful. Adhesions over the clitoris makes having orgasms harder. And so you really have to get frank with them and say which of these, because there's different treatments for libido, painful sex, orgasm. And the other thing is just, I really feel like I'll even tell women that are coming in their 50s and 60s. I mean, because there are medications for libido that are PRN. There's actually a little shot you can give yourself, but it's 45 minutes, so they actually have to plan
So
date night.
it's essentially like Viagra
for women. Yeah.
women.
And so then like, oh, I said, there's nothing wrong that we have to change. You change how you exercise as you get older. No reason why we can't change and adapt and still enjoy our sexual health in a relationship and have to have a little planning with it. So, I mean, I think that's important too, that you just talk through that there's many women that go through it. It's okay. And what I want is you and your partner to be happy. So like example, a woman today has no libido, this or that, she doesn't care. There's no reason to go into it and treat it. Other women, it's a big impact on their life. So being able to have them feel comfortable to talk about it, and then being able to get those specifics on which of those things are bothering you, and then what treatments are available. Once again, considering, and it isn't even just cancer, it's also considering their other medications and their health. So, but there's definitely medications out there for true. If it's like everything's okay down there, but it's my libido, the desire, treatments for that. If it's more the vaginal dryness, and there's definitely non-hormonal ways to manage that. There's a Mona Lisa procedure touch you can do if you really don't want them to have estrogen.
And that's a trademark name for a type of, is it a laser type procedure to change the lining of the
Yes.
vagina.
Yes,
to,
it builds collagen because the vagina, like I mentioned, it gets thin, it gets very pale because there's no blood supply and the elasticity. So I kind of use the word, it's like it plumps it back up. I mean, it gets blood supply there, collagen back there, gives that elasticity back there. It doesn't work for all women, but for women who don't want to wait months to have the estrogen kick in or can't have estrogen in the vagina, it's a nice option. Of course, not paid for by insurance, but
Mhm.
that's one of the more respected of the procedures,
The procedures.
out there.
And talking about, sexual health, it would seem you can't ignore the relationship,
Absolutely.
and that
Yeah.
some libido and even some physical aspects probably have to do with the relationship. So to truly address sexual health, at some point, having the partner as part of the conversation, it would be important, I would think.
It is very much. And so we also have names of sexual therapists because, like I say, even that's not, I mean, like I say, it's just trying to rebuild that between two people. And how can we make that a very special moment? But it's different than when you were 30. It can be, and so they approach it that way. So yes, I start out by telling women, if you don't like your husband, my libido medicine's not going to help you. So, just joking with them, but really you do have to ask those kind of questions, or they've got kids running around, or they're worried about their medical bills and all their doctor's appointments. And so if you've got all that up in here, it's hard to change that. So we definitely address those issues, and we have to make sure that that's good, then you can proceed. So it's the hardest thing is vaginal dryness we can treat. There's some things we could do for the orgasm, but to truly get to the libido, just because our minds there's so many layers to libido, that you have to look at each of those very carefully. And that's why it takes so much time and it's hard to do in like a regular primary care office. I mean, it's just
Yes.
tough to do
Yes,
that.
and especially it's okay. You've just in primary care. You've just spent 20 minutes with the patient, and on the way out. Oh, by the way, I also wanted to bring up.
But always what I want to try to get across for primary care physicians or for patients who are listening who talk to their primary care may realize that they can't help them, but just say, hey, I'm having this. Can you refer me somewhere?
Yeah.
So they don't necessarily have to have the answers. They just need to know where to refer
Yes,
them.
sometimes it's just knowing the resources.
Yeah,
'Cause
exactly right.
no one can have the knowledge of all the specialties.
Yeah.
Let's shift gears just a little bit and talk about the intersection of cancer with women's health. So let's talk about women with cancer, and maybe divide it into two general categories. So breast cancer, where a woman may well get chemotherapy that affects the ovaries, and then may actually get anti-estrogen therapy and the role that plays. And then after we discuss that a bit, then maybe let's talk about pelvic cancers, where actually radiation to the pelvis is part of the treatment, and the role that may play in women's health and sexual health. So let's start with the most common cancer in women, and that's breast cancer, and the role that breast cancer itself, or breast cancer treatment more commonly, may affect women's health, and what you've seen and what's been your experience at the Women's Center, helping women with breast cancer who have experienced issues related to women's health, menopause, and sexual health as a result of their breast cancer treatment.
And part of it is that they've got multiple doctors already and multiple appointments, and that all wears on them. So fitting in and trying to figure out which doctor they should talk to about it. Should I talk to you? Should I talk to Dr. Deming? Should I talk to Dr.? So just trying to help them sort that out.
And then there's also this existential issue of anxiety related to cancer and fear of recurrence.
And fear that, I have this freckle that's changed and worried. So there's a lot of reassurance that has to happen. And I just reassure women. I say, if you have a worry, don't sit and worry. Just tell us, and then we'll tell you whether to worry about it or not. But if it's nothing to worry about, then help them let that go. But so with the breast cancer, it is the biggest part is when they reach the anti-estrogen phase, and you block that for them, or not you, the other.
Right.
Yeah.
That's a big part of breast cancer treatment is blocking
Yep.
estrogens
Yep.
and giving
Yep.
anti-estrogens and stopping the production of estrogen.
Yep.
Estrogen.
So the biggest thing I see is the hot flashes and night sweats. And it's hard to imagine, but some of these women will really just describe they just feel like they're combusting, and it drastically affects their trying to be having a meeting with someone, and they're breaking out in a sweat and they're embarrassed, and so they don't, and at night they're waking up how many times, and the husband's freezing and they've got fans and air conditioners. That's probably one of the biggest quality of life ones, because that leads to fatigue, and you're not getting sleep like that, you're going to be more irritable. So discussing with them the non-hormone options of treating their hot flashes and night sweats, and the sleep, the mood, like you say, I think that always encourage the counseling if we can. And then, like I say, talk about the different antidepressants depending on what therapy they're on, and their relationships and their support. Trying to think what else. And the vaginal dryness is a big one. So trying to talk about educating them that the vaginal moisturizers and lubricants, and which brands are better, because not all the over-the-counters are treated equally once you're older, or have, when they're young, they can pick whichever one they want. But as you get older, we review the right pH, the right osmolality of the different moisturizers and lubricants, and just any other concerns they have with their treatment. But I would say the biggest thing is once they're either on tamoxifen or an aromatase inhibitor.
Okay. And then women with pelvic cancers, and that could be the uterus, the cervix, the vagina, or it could be pelvic cancers related to the bowel, either the rectum or the anus, where those patients may receive chemotherapy and pelvic radiation. And all of those have consequences in terms of sexual function.
Yeah. And I've got an 18-year-old who's had her ovaries removed, and hopefully her on ice can be replanted, but she's surgical menopause was started at age 17.
Oh, wow.
She's got a whole life left without estrogen. And so looking, like at their bone health and reducing their heart disease risk, and all of that's associated with blocking the estrogen. So we also see young women too that go through it. But once again, if they don't have the estrogen, we deal with that. But that also tends to be a lot more of the vaginal health, the shortening of the vagina.
With the radiation. So for example, if it's rectal cancer, estrogen doesn't really come into play in terms of the risk, but the radiation or the chemo may have stopped the ovaries from functioning. And then you've got also the side effects of the scarring and thickening of tissue as a late consequence of the radiation.
Yep. And once again, that's where the combination of, if I have any concerns over working with their oncologist, whether or not we can use hormone just vaginally, and then the pelvic floor physical therapy is huge, and the dilators. I know that seems tough to talk about, but like I say, there's different ones, and they really need to have a good instruction on that. And then the support,
and to get the treatment involved early. Because, again, I'm a radiation oncologist, but the radiation changes happen over time and then develop this thickening and scarring. And if we don't start addressing those early on, by the time the fibrosis, which is the dense scar tissue, happens, then trying to correct that becomes almost impossible.
Yeah. I have another gal, she's just a young gal about to undergo vaginal reconstruction. You get the University of Iowa, just because there's just too much that we can't do anything more about it. So she's going to have to actually have that surgery. So
in you've touched on, but I'd like to dig a little deeper into the other therapies besides a medication. So you've talked about a pelvic floor physical therapist, and I mean, do they? I would imagine with a woman, they are actually doing a vaginal exam, and maybe the physical therapy might also involve manually inserting their
yeah,
fingers and
it's
doing
exactly right.
some.
Because if you look at the muscles that support the pelvic floor, there's quite a few different. And when you reach in the vagina, you can palpate those different ones. So you can kind of see which ones are tight, which ones are tender. And then they can do this biofeedback and measure and see if they're doing the exercises right. There's one of the dilators that I like to use too, starts out very small. And instead of using different sizes, and actually, just hold the battery and it starts to expand a little bit. And then when you feel it's at the taut spot, you turn on a little vibrator, and it, like you say, it's kind of like breaking up those little adhesions. And so you can get a little bit further. So the combination of the dilator with the vibration can be very helpful versus just the silicone dilators.
Yeah, and this type of physical therapy doesn't happen at the same place where you go to get your
No.
knee range of motion back after a. Yeah, so this is very specialized
Yes.
physical therapists who have very specialized
That's
training, and as you
that's
said,
all
it's
they do
called
all day.
pelvic
Yes.
floor therapy.
Yep.
Yeah.
And I can say, even in my when I was doing primary care internal medicine, I didn't realize the full value of it, and underutilized pelvic floor, because I just didn't realize what all they really can do.
Yes. And
for a
getting
bladder
them involved early on
early
in
on.
the care of patients. I think especially those patients that are going to have surgery or radiation to the pelvis.
Yeah.
You mentioned other ancillary services that you have at the Women's Center. We also have them in the Integrated Medicine program in the Cancer Center, but massage therapy, chiropractic care, OMM, osteopathic manipulation. Maybe talk a little bit more about the role of those integrated medicine therapies on women's health in general.
So our medical massage therapist just went back to nursing school, so we are currently without one, but she loved working specifically with cancer patients and did additional training with that. And then which one other did you mention?
So massage therapy, acupuncture,
Yeah,
chiropractic care,
yes.
OMM.
So the acupuncturist we've never gotten. That was one of our goals. So then COVID kind of happened, and so I don't know if they're going to still look at that. But yeah.
So
What's nice with the chiropractor is, he's right there to consult with us.
And do you think that? So I'm still learning the real value, and we've had conversations here at this with chiropractors, with acupuncturists, with massage therapists. So the role of acupuncture in managing menopause symptoms, the role, like, does a chiropractic care, do you think that affects hot flashes?
So with the North American Menopause Society, they put out like a position statement of the different things, non-hormonal, that help and not help. And I haven't seen too much on actual chiropractic yet. You can do stellate ganglion blocks too.
Okay, and that would be
the
injecting medication to kind of turn off a nerve. That might be
for the hot flashes and night sweats. I've only had a couple women do that.
Okay. And Val, I know you were a nurse, and then you went to medical school at an osteopathic, and I'm sure that as part of your training, you learned osteopathic manual techniques. When you were in medical school, were those used at all in women's health, or was it?
You could do additional training. The biggest thing I saw was women's health, was them helping OB patients so that their delivery would go smoother.
Gotcha. Use those techniques to help
I have
open
to
up.
ask like Dr. Bolshow. She was in it more recently,
Okay.
but yeah, I didn't, nothing that I learned about helping, menopausal women per se, or the OB
Yeah.
part.
So I
But
think
I'm sure they made advances. I've been out of school a long time.
yes, there's
Yeah.
lots more that it's being actually. I think the medical profession and the public is much more interested in
Yes.
well-being and things that we can integrate into our health and our health care
Yes.
that's different than just taking a medicine.
We originally also had an integrative medicine physician that would consult there. Fortunately, he retired, but that was great, because if they came with a long list of certain supplements that I wouldn't know about, or in general, he would talk to them about integrative medicine. That was nice, because I just find, even like having people do counseling, having a counselor right there, they're much more likely to follow up, rather than say, call this number, go down the street and go. If they're right there in the
Right,
office,
and maybe we'll get you in a month.
right. And
they're
I
in
can go
tears
down
right
and
now.
talk to her. If she's free, she'll come down and meet the patient. And that's just so.
Yes, to be able to integrate all those services in the women's center. You know, Val, if it's okay with you, I think we're going to open up to questions.
Sure, absolutely.
So we've got a live studio audience here with us, and we also have individuals that are watching us live streaming. So we'll do a little Q&A session.
I've got a comment from an online viewer, and it has to go back to the hot flashes, which you said is most commonly talked about. And they're making a joke about having to run the ceiling fan. This is from Angelina, while the husband is freezing. But this is such a hot topic.
Yeah.
Pun intended. But because it seems to be so difficult to resolve. There seems to be such little relief, that it's such an ongoing problem. Is it something that's treated
That's because
effectively?
they haven't come in yet.
Yeah.
They're definitely good treatments for it. Okay. And so if they're having that, I mean, like I say, if it's not really bothering her and her husband, then that's fine. But if it's disruptful sleep, I think there's definitely multiple therapies. I would just encourage them to come in, because like I say, so I have the residents train with me. So we're trying to raise awareness with the young doctors coming through that there's treatments for these. And if you're not comfortable with it, refer. But so we have a very good success rate in helping those vasomotor symptoms. At least, like one gal today, she goes, well, I don't want to bump the medicine because of side effects, but I'm at least 50% better. And to me, that's great. Other people can get 90% better, but some women, just to take some edge off. I mean, they go out naked in the snow in the middle of the night because they're so hot. But whoever you said that was, come on in. We definitely have some treatment options for you.
And the question that I have had to do with the antidepressants. They've come under criticism recently. Some people believe that they're not really very effective, not like we thought that they were. But it sounds like you've had some success in some circumstances.
For depression or for hot flashes?
In any circumstance, yeah.
Right. So with the nice thing about the hot flashes and night sweats using the antidepressants, we can usually use a much lower dose than you need for depression. So that also makes women feel better, that they may not get all the side effects.
And let me just kind of clarify. So you're not giving antidepressants because you say, oh, you're not really having hot flashes, you're just depressed. It's that physiologically, the antidepressant can have a physiologic effect.
Yeah, estrogen and serotonin are very much related.
Yes.
Yeah.
So it's
yes. We can use if they don't like the Oxybutynin or gabapentin, we use the antidepressant even if they truly have absolutely no mood issues.
Yes.
We put them on.
And
the
that's the point I was making.
Yep.
Is that it's not like you're treating that you think their hot flashes are caused by the depression, then you're using antidepressant. It's that physiologically, pharmacologically,
yes,
the antidepressant has an effect on their vasomotor.
Yep. Depending on the dose, we can get up to almost 60-70% reduction with the antidepressants. So the other thing I would say is, if people are really worried about it, we also actually do DNA pharmacogenomic testing. So we swab the cheeks and you send it off, and it comes back and says which of the antidepressants, they metabolize the best because they're metabolized through the liver. So usually we just start with one or two, but if somebody's really, really worried or have been through multiple ones, we can do that testing. It takes about 2 weeks to come back, and it goes over all kinds of different medications, but especially the antidepressants and their best chance to have lower side effects and metabolize it. Sorry.
Other questions? Thank you.
Yep. She said to try one.
Hello, Val. How are you doing tonight?
I'm very good, thank you.
Thank you for coming tonight and enlightening us. I had a small side conversation with my wife here, and we're thinking, okay, the insurance part and how it's all paid. Can you touch on that just a little bit more, please?
Yep. It's so since you're coming to a regular office, it's just billed just like any other medical visit. The only thing that wouldn't be covered would be like that laser treatment to the vagina. But if the office visit is no different than if you went to see your regular doctor, and then so the medications would be covered according to a formulary. So insurance really isn't a problem in that respect. But good question. You don't want to add more bills.
And same with the pelvic floor therapy for
yes.
those appropriate. That's physical therapy, and it's covered by insurance.
Chiropractor, I think everything in our clinic. I don't think there's anything that's has to be cash pay. It's all through insurance.
Just want to clarify, you do like the women's health, all their exams and
Yes. So
all the tests.
of course we love helping women with their problems, but we also do the preventative health. So we have what we call the Fit for You physical. So that looks at all the appropriate cancer screenings, labs, immunizations. We calculate your bone health risk. Do you need a bone density earlier? We calculate your breast cancer risk. We can coordinate your physical, your mammogram, your bone density all on the same day. Or a lot of times they'll come see Dr. Beck or Dr. Torstensen and myself, especially when they're coming from out of town. So we have a nurse navigator. If people aren't sure, like who should I see there? You call the nurse navigator and explain what symptoms you have. And they'll say, I think it's best you see Valerie, or no, you see so-and-so. So she can also help direct that and coordinate the appointments.
Okay.
And just to reiterate that the Women's Health Center, not only are there internal medicine physicians that are specialized in menopausal and sexual health, but the general care of women. But as you mentioned, we also have at the Women's Center uro.
Yeah, we hadn't talked about that yet.
Gynecologists,
Yep.
And we have at the Women's Center, obviously the breast specialist, the breast surgeon. Yeah, let's talk a little bit about the urogynecology specialty and why is there a urogynecologist at the Women's Center? What is a urogynecologist and what role do they play in women's health?
Yeah. So they're a gynecologist and does extra training for the urology part. So not like kidney stones, but bladder. So really not kidney stuff, but bladder. So if you do need bladder surgery or you have you've had adhesions in your bladder stuck to the uterus, I mean, he just can address both. And also women who have stress incontinence, you can do pessary rings, certainly any gynecological things he can take care of too. So midlife women who have abnormal bleeding, it needs to be researched. So he's great at all of that. So if any gynecological needs above like what I can do and bladder issues, he can help you decide whether you still need to do pelvic floor or you know what, you need surgery or so it's wonderful to have him there too. And they do urodynamic studies there. They've got to check all the bladder capacity and all of that.
Just out of curiosity, age-wise, where would the majority of your patient population fall?
40 to 70.
47.
I get some a little older because some women continue to have hot flashes in towards 80, unfortunately. And well, start to some of the mid 30s, but I'd say 45 to 65. Those are the very biggest ones. But we're happy to see anybody. I had a 90-year-old lady not too long ago, and she's like, this down below just isn't acceptable anymore because she was just sitting. I mean, it's so your vaginal health is so important, even if you're not sexually active. You can get increasing bladder infections. It can just irritate women to even wear underwear. And so she came, and she's just a happy little camper, but it doesn't even have to do with sexual health. She just felt so bad down there, but 90. So we take any age.
And you mentioned briefly the COVID era. How did that affect women's health in general? And I don't know that there's any normal to return to, but are we coming out of that? Are things changing?
Well, with at the Women's Center, especially since we have a lot of cancer patients there, they really screened people for COVID, and they really couldn't come there. So personally, I haven't dealt with a lot of the COVID patients just because we haven't had to do that. But yes, sometimes a lot of women come in, a little bit of a period change, or they feel more. Brain fog is another thing that happens when you block the estrogen. That is a true thing where you can't remember things. And so some of those symptoms can mimic kind of perimenopause symptoms versus lingering effects of COVID. So sometimes we just kind of have to wait and see. But I have been surprised. I'll see some women back and say, you know what I complained to you about? Yep, that was gone. It took about 2 months after COVID and it was gone. So.
Any other questions? Well, Valerie, this has been great. Dr. Stratton, thank you for all you have done to help my patients in particular, and for the women, and actually being part of creating the Women's Center, that model of a multidisciplinary clinic that brings integrated medicine into the clinic.
I just might add, my retirement date is 3 weeks from tomorrow.
But the good news is
I have good news.
that it's Circle of Life, as you're leaving.
Yes,
a new
2 new physicians coming, and one of them is here with us tonight, and she's internal medicine based, and then will also be certified in menopause and the sexual health. And then that's Dr. Erin Volschow, and then Dr. Karen Kemp Glock has already joined, and she's done OB-GYN most of her life and is just focusing on menopausal and sexual health. So they'll both be certified in menopause and sexual health. So they're both there and will be able to carry on and
wonderful. It's
build
taken
even
2 to
further.
replace.
There you go.
There
Yep.
we go. Well, thank you, Dr. Stratton, for being with us. And thanks, everybody, for attending. If you know someone who would benefit by listening or watching this program, beginning tomorrow, it'll be available on the Above and Beyond Cancer YouTube channel, and it will also be available on the MercyOne Cancer Center website. So,
And I know I've seen some of you out there. You said you're watching tonight. So hello.
thanks. And please join us again next week. Thanks, everybody. Bye-bye.